Let me know when you're recording. Okay, so welcome to our webinar. This one is the ins and outs of prolapse. My name is Kenzie Taylor. I'm a doctor of physical therapy, graduated from Rockhurst. And then Julia, I'll let you introduce yourself.
I'm also here, Julia Foster. I graduated from KU Med, and we are both here in Kansas City.
Perfect. So, agenda for today. Basically, we're getting into why prolapse happened, the symptoms of prolapse, the anatomy of what the pelvic floor itself is and how it relates to prolapse, the different types of prolapse that can occur, and kind of how to indicate like what type you might have, management of the prolapse, what exercise looks like with prolapse, and before and after surgical options. Again, we're just bringing awareness to what prolapse is in general. I feel like sometimes it can be a really scary term for people and seem very life-threatening, but the more awareness that we have of it, the more knowledge that we'll have and the more understanding and grace that we'll give our body for everything that it's going through. Okay, so first question, why does prolapse happen? You might have this question if you currently have a prolapse going on, or if you're here just to learn a little bit more about prolapse, maybe your friend or your mom has talked about it. But basically, it can happen for a few different reasons. It could be that downward pressure during childbirth, or even just like carrying multiple babies, pretty heavy babies as well. Chronic constipation or straining puts a lot of stress on our pelvic floor muscles, causing prolapse. Breath holding during exertion. So if you are, a heavy weightlifter, you exercise a lot, but you don't have great breathing mechanics, that can cause some prolapse issues to happen. Again, that same thing, improper pressure management during exercise. Some connective tissue disorders such as Ehlers-Danlos syndrome, which is a lot of like ligament laxity, that can create a prolapse within us. And then just pelvic floor weakness and lack of support in general. And we'll get into the anatomy of that next. Okay, so the anatomy of the pelvic floor. On the left here, you can kind of see like a bottom up view. So this would be like looking into like vagina, rectal opening and everything. But you can see on the left side, there are those sit bones. And then we have pelvic floor muscles that run side to side from sit bone to sit bone, even from pubic bone to tailbone. So it looks kind of like a triangle going on, not triangle, sorry, maybe an oblong rectangle. But there's many different structures in that pelvic floor in terms of pelvic organs, rectal openings, vaginal openings, urethral openings. But contained within all those are those pelvic floor muscles. On the right side, you can kind of see how pubic bone and tailbone are connected via that system of pelvic floor muscle. So almost like a sling. Then right above those, we have that yellow structure, which you can guess is bladder. And then we've got uterus, and then we've got bowels. Okay, so some symptoms of prolapse. It could be either like that feeling of heaviness or pressure in the genitals or lower abdominal region, just kind of having some achiness down there. You can see or physically like touch a bulge at your genital openings. And this could be, rectal or vaginal. That feeling of something's like falling out is what patients will say sometimes of the vagina. Discomfort during sex, maybe things just feel like they're in a different position than what you're used to. Other symptoms include a feeling of the bladder not completely opening, maybe some difficulties evacuating stool or feeling like the rectum can't completely empty. Other things, needing to assist or splint a bowel movement. Usually that's a feeling that you get when you're having a bowel movement. You just feel that need to splint. And we'll get into that a little bit later. Other symptoms would be pelvic pressure that worsens throughout the day or with a lot of activity. Oftentimes we'll have patients say like, after I'm like running a bunch of errands all day, that's when I feel it worse, or maybe after I go on like a long walk in the evening. And sometimes you have no symptoms at all. So there's a few different types of prolapse. We'll start on the left side. So that would be that cystocele. So that is when bladder is falling into vaginal wall. I'll be as simple as I can with this. Basically, weakness in those pelvic floor muscles cause bladder to sit a little bit differently. It puts pressure into vaginal wall and then sometimes can prolapse out of vaginal opening. Then that rectocele, it's basically the same thing that happens with bladder, except for the rectum pushes into a vaginal opening. And then we have a uterine prolapse, and that is when the uterus, which is connected to the vagina itself, starts to prolapse down and out as well. So it could be one or the other, or it could be a combination. And that's where it becomes important, seeing a pelvic floor therapist, seeing an OB/GYN that can help diagnose these, and kind of indicating which type you have is important as well. So if you were to get a diagnosis from someone, they also grade the prolapse. And that is just indicating like where the organ itself is sitting. So normal anatomy you can see on the left. And this would be a uterine prolapse. On right next to it, stage 1. Basically, that's when the uterus is in the upper half of the vagina. So you can see it just sitting a little bit lower than where it should be. Stage 2, the uterus has descended nearly to the opening of the vagina. So if you just barely open vaginal tissues and have you kind of bear down, or even just standing there, sometimes we can see that tissue sitting there. Stage 3 is when the uterus just protrudes out of the vagina a little bit. And then stage 4 is when it comes completely out of the vagina. Again, it can be kind of a scary concept for patients to think of, but we're just raising awareness for what prolapse is and then getting into ways to prevent it.
Awesome. And so a quick question that I get sometimes is, how can I check this? And so actually using a mirror. So standing up and maybe putting your foot up on either like a toilet seat or a little step or step stool, and then using a mirror to visualize the perineum or that pelvic region to see if you notice any tissues descending. You can observe the tissues as you're standing there, or you can even gently bear down by kind of holding your breath. Now, that's something that we don't want you to do often to check, but for a quick assessment to see, is this something that I am dealing with? If you're having some of those other symptoms that we mentioned earlier, that can be a quick way to check and see if you see any tissues descending down that maybe wasn't there before. So we have a quick quiz, and I'll just read through these. True or false? I should never lift heavy things with prolapse. True or false? Prolapse can only be managed with surgery. True or false? Physical therapy can only help in mild cases of prolapse. And then lastly, true or false, it is very important to manage my pressure during exercise and toileting. And just kind of thinking through some of those answers, I feel like this kind of debunks a lot of myths that might be surrounding prolapse, in the sense that a lot of people think that only surgery can help with this, or that physical therapy can only do so much. But for some of our answers here, all of them are false except for the last one. So it is true that it is important to manage your pressure during exercise, and especially toileting as well. So managing that constipation that we said earlier. So how do we make these false statements true? You can lift heavy things, but you need to make sure that you have good form, mechanics, and you can manage your pressure. When I say managing your pressure, a lot of times what we can see with physical therapy is a lot of breath holding. So a lot of people holding their breath as they're lifting something heavy or as they're getting up from a deep chair or a deep squat. And so when you're managing your pressure appropriately, what that means is it's not building up inside your abdomen. When it builds up inside your abdomen, that causes unnecessary pressure either outward or downward. And so especially if you're suffering from pelvic organ prolapse, then it's more likely to go downward. Vice versa, sometimes with our male patients or sometimes with our postpartum patients that have a diastasis, if they're not managing their pressure well, then it might result in things like forward pressure dismanagement. So a coning or doming of the abdomen at the diastasis line or a hernia. So you can lift heavy things. That is definitely a myth, but working with someone who can help you have good form and pressure management is key. Next statement. Prolapse can be managed with surgery, pessaries, PT, and exercise. It's not just surgery. There's lots of different options, and there's lots of research actually to back all of these options. So sometimes it's important wherever you're at in your journey, whether you're suspicious that you have a prolapse, you're worried that you may develop a prolapse, or you have a stage 3 or 4 prolapse, you can combine some of these things together or start with certain steps and then build your way up based on how your results and how your own symptoms present. Next one, physical therapy can only help or can help in all cases of prolapse, not just mild cases. And so even if you are suffering from a higher stage, like a grade 3 or a grade 4, and you do need to go the surgical route, or it's suggested that you go the surgical route, setting yourself up for success before and after that surgery is really key. So that way you know how to manage your pressure, you know how to strengthen and find your pelvic floor muscles. So that way you're not going back to any bad habits that might now push downward on that new surgical site or the suspension that they do during your prolapse repair. So how do we manage prolapse? Pelvic floor physical therapy, a pessary, surgery, or like I said, a combination. And we'll dive into some of these here in just a second. So physical therapy tips to help you get started. What we want to make sure as we're setting goals for you, whether it's, again, a stage 1 or prevention or a stage 3 or 4, is learn to connect to those pelvic floor muscles, manage that abdominal pressure, and then using tips and tricks like blow as you go and exhale as you exert yourself. That is going to be one way that you can help to, again, manage that pressure so it's not building up within your abdomen and potentially pushing down. Because think of this, if you open like a Coke can, right, and then you're blowing out, then whenever you're doing different activities, your pressure gets released forward and up out of your mouth by blowing out. If you're holding your breath and you're closing off the back of your throat, then your pressure has nowhere to go but either down or out. So making sure you're breathing. Some other tips that we teach you is with a cystocele. So remember, that's when the bladder is pushing into the vaginal opening. That is when double voiding may be a good tip or trick for you to try. So what double voiding is remember, you can kind of see here, if you can see my mouse, the bladder is in the front, but with the prolapse, the bladder does tip backwards in towards that vaginal canal. And so with that, you can imagine that typically as the bladder empties, it's upright, so it can just funnel and filter out like normal. But as your bladder empties potentially with a cystocele, there may be this small little pocket that can get a little bit of urine trapped in there. So why that's important is because urinary retention can lead to things like an increased risk for UTIs. It could lead to more frequency. It could lead to urinary leakage. And so double voiding is a technique that where you're sitting on the toilet, you empty your bladder, and even when you feel like you're done, before you get up and, go to wipe and pull up your pants, leaning forward and doing kind of like a little shimmy shake, and then seeing if that gets any more out. Or you can even stand up, do the little hula hoop shimmy shake, and then sit back down and see if anything comes out. What that does is you're moving your body to potentially empty or get rid of any urine that was kind of trapped in that pocket there. Now, similarly, for a rectocele, Kenzie mentioned earlier the need for splinting. And so splinting is not a bad thing. It's something that can actually be a really useful tool. So that way you're keeping that rectocele pocket empty. This is going to lead to better bowel habits in terms of feeling like you're fully emptying more, maybe dealing with less constipation. And so, like you can see here with your rectocele, that pocket is potentially pushing forward into the vaginal canal. And so what you're going to want to do is line the rectum up to be more upright. So 2 ways you can do that is by using your finger. Now, this image I don't love necessarily, but it's one of the only ones I could find because this person's using their index finger, and it's a little bit tricky to do in terms of orientation. Because if you think about it, if you're sitting on the toilet and your hand is coming back and you're trying to use your index finger, it's a little tricky. I would suggest actually using your thumb, because then you can insert your thumb just to, the base knuckle into the vaginal canal, and then use pressure pushing backwards, like towards your tailbone, towards your rectum, to splint that back wall. So that way that pocket is more upright. So that way when you do your pushing and your breathing to evacuate your stool, that it's not getting trapped there or stuck there. And then in this picture here, there's this little device. This device for a rectocele is called a FEMZE, FEMMZE. And so they sell them on, I think, Amazon or CMT Medical. So that way, if you're kind of weary about using your hand, or you'd rather have a tool, or if you need an assistive device due to any mobility issues with your hand or with your back, not being able to reach the area, this is an excellent option as well. Earlier, I mentioned pessaries. So pessary is another way that we can potentially help with prolapse. And so a pessary is a removable device. So it is not permanent. It is not surgically placed, but it is fitted by a trained professional. And so people who fit these are usually at your urogynecology offices, sometimes your gynecology offices, or a nurse practitioner or a physician's assistant that has experience and expertise in fitting a pessary correctly. And so there's many, many different types. So there's 3 different types on this slide here. But if you look up pessary, there's probably about like 30 or 40 different types. And so that's why it's really important in order that you find a provider that has a lot of experience with this, because it's not a one size fits all. Everyone's a little bit different, like you saw with kind of the different presentations, the different grades, bladder versus rectum versus uterus. And so everyone is a little bit different. And so that's why you want to find what works best for you. Now, what's nice about a pessary is that it is a non-surgical option that, again, is removable. And so you, based on, again, what you decide with your practitioner, you would have to remove it for things like intercourse. You could remove it to clean it, usually about every week or so, or every few days. But I also know that there is a few types that you can leave in for longer, and then you can go in to get it cleaned and refitted if, again, you have some mobility issues or it's tricky to get in and out on your own. So when surgery is indicated, so say you have surgery on the books, or you've tried physical therapy, you've tried a pessary, and it just maybe didn't work for you. When surgery is indicated, before surgery, these are the 4 key points that we would want you to focus on. strengthening the pelvic floor, working on your breathing patterns, learning to manage your abdominal pressure with day-to-day movements and exercise, and improving your posture for your core and your pelvic floor to work optimally. So what I mean by improving posture as well is sometimes if we find ourselves in like, a slouch position, then what that does is when we're rounded forward, well, again, that guides our pressure downwards. Or if we're in a position where our pelvic floor or our glute muscles maybe can't work as optimally, then our pressure management and distribution or even our breathing patterns may not be the best. And so working with a physical therapist, a pelvic physical therapist can help with all of these things. After surgery, it may also be beneficial to get a few consults on the books or a few treatments on the books to discuss things like how to avoid constipation, to make sure that you are having good bowel movements so that way you're not again, pushing downward on that new surgical site. We want to preserve the hard work that the surgeon put in to suspend all of those structures. Maintaining a healthy weight can also be very helpful. And then again, working with a PT to get back to safe exercise and lifting. It is not a sentence that you are not allowed to lift. You are not allowed to do exercises. You are able to get back to those. We just need to make sure you return to them safely. So how to get in touch with us. I've included our clinic information and also our phones to our different clinics. Kenzie is at the North Kansas City Clinic here in Kansas City, and I am at the Brookside Clinic in Kansas City, Missouri as well. And our clinic does offer free 15-minute phone consults. And so if you still have questions or if you do have anything that you're wondering, is PT right for me? Or sometimes I have these symptoms, but I'm not quite sure. Even just getting some information over the phone can be helpful. So that way we can let you know if PT is a right fit for you. And I'm going to stop my share here. And